This video is going to be all about cardiac transplant patients and how we take care of them for when they're not having cardiac surgery. So first of all, why are these patients getting heart transplants? Usually it's from severe heart failure, and it's probably because one or both of their ventricles are not functioning properly anymore. Heart transplants are becoming a growing field of medicine within our country, and there's about 5,000 to 10,000 transplants done per year worldwide. This number is only expected to increase in the coming years, and that's why it's so important for us to understand how to take care of these patients when they're coming in for surgeries unrelated to their heart. Let's review a little bit of the physiology. The things that are removed during the transplant are going to be the diseased portions of the heart, part of the aorta, and the main pulmonary arteries. The cardiac plexus gets disrupted during this process, and the atria that remains usually is still innervated, but there's no conduction along the suture lines. These patients end up with a resting heart rate around 90 to 110 beats per minute. These hearts become very sensitive to loading conditions, otherwise known as becoming very preload dependent. Occasionally on EKGs, you can see 2 P waves, and that's because there's atrial conduction from both the recipient and the transplanted heart that's going on. There's also a higher risk of developing AFib or a flutter later on during the reinnervation process of this new heart. 3 things that we look out for are going to be infections, rejection, and allograft vasculopathies. There can be high rates of infection, especially for patients who are taking Tacrolimus as their anti-rejection medication. So special awareness and consideration should be taken whenever doing invasive procedures like placing a central line. And they also may not have the same signs and symptoms of someone who's experiencing an inflammatory reaction or an infection. For example, you might not see an elevated white blood cell count, or you might not see fevers. Rejection can occur anytime a patient stops taking their immunosuppressive therapy, and that can come in the form of weight gain, fevers, chest pain, shortness of breath. The first thing you're going to want to do is make sure that they get back on their immunosuppressive therapy, and also take an endocardial biopsy to prove that this is rejection going on. Emergent therapy for patients who are having rejection are going to be IVIG, plasmapheresis, and potentially mechanical support to support the failing heart. Allograft vasculopathy is when you have atherosclerosis or narrowing of the coronary arteries in the transplanted heart, and this can happen for a variety of different reasons. A couple reasons could be from the immunosuppressive therapy or from infections from like a CMV virus. The rate of this happens about 10 to 20% in the first year and up to 50% in 5 years. In terms of preoperative management for these patients, it's nice to have an ECG so you can assess if there's any degree of heart block. If you're worried at all about rejection, then the endocardial biopsy will confirm that diagnosis. You can also get an echo to make sure that there's no failing of the ventricles and to rule out any allograft vasculopathy. Some of the labs that are useful in these patients are going to be a CBC, electrolytes, renal function, and liver function tests, as some of these can get disrupted by the immunosuppressive therapies that these patients are on. You can also check different blood levels of those immunosuppressive therapies to make sure that they have an adequate level to prevent rejection. One of the biggest concerns with these patients is their decrease in heart rate response to hypotension. So a majority of providers will do general anesthesia as opposed to neuroaxial anesthesia, so that they don't have that sympathectomy that happens with a spinal anesthetic. If you do need to increase your patient's heart rate, just know that atropine is not going to work in these situations, and you're going to want to use isoproterenol or epinephrine, which will both increase the heart rate, and then epinephrine will also help increase your blood pressure as well. Post-op management gives special attention to preload or volume status, what the renal function is, and decreasing any risk for infection.